In healthcare operations, practice administrators rarely write public reviews about their outsourced support. But recently, a psychiatry and TMS wellness center in Great Neck, New York, published exactly that. First VMA experience highly positive, trained staff. That brief review represents a statistical anomaly. Getting a new administrative layer to execute perfectly from day one is exceptionally rare in modern outpatient care. The national context shows why. Psychiatric care facilities are operating under severe structural bottlenecks, struggling to manage high patient volume with limited resources. According to the Health Resources and Services Administration, 62 million U.S. adults had a mental illness in 2024. Nearly half receive no treatment, and the national average wait time for behavioral health services is currently 48 days. Research shows psychiatrists spend the highest proportion of their time on administrative work, specifically 20.3%. That translates to a tangible daily loss. For every hour seeing patients, roughly 15 minutes is absorbed by non-clinical tasks. Combined psychiatry and transcranial magnetic stimulation, or TMS, centers carry an exceptionally heavy version of this load. Approving treatment requires failed medication proof, formal diagnostic paperwork, and complex payer-specific documentation. The American Medical Association quantifies this burden clearly. A single physician averages 39 prior authorization requests per week, draining 13 hours of clinical and staff time. When those authorizations fall to undertrained staff, an operational cascade occurs. Submissions go out incomplete, and denials stack up. The physician is then dragged into peer-to-peer review calls with insurance representatives. This administrative friction creates a structural failure. It pulls clinical focus away from patients, artificially restricts practice capacity, and actively worsens that 48-day national wait time. Practice owners frequently treat the front desk as minimal overhead, yet they face a constant cycle of local hiring, while operating costs soar and the patient experience degrades. In a 2024 MGMA poll, 53% of medical leaders identified finding qualified candidates as their top challenge. The financial impact is immediate, driving an average 11.1% upward trajectory in operating expenses. Independent practices are forced to budget heavily for cost of living and merit increases, bleeding capital just to compete in a broken local hiring market. The true cost, however, is clinical. Psychiatric patients build therapeutic relationships over time. When the person answering the phone is constantly turning over, that instability destroys patient trust. Patient engagement via live contact operates as a direct clinical intervention. It ensures a vulnerable patient actually attends their appointment. This gauge visualizes data regarding automated systems. Relying solely on voicemail reminders results in a massive 24% patient no-show rate. But when practices use trained live contact, the no-show rate drops to exactly 3%. The financial exposure here is severe. Sleep clinics average a 39% no-show rate, costing independent practices an estimated $150,000 in annual revenue loss. Treating the administrative layer as a sunk cost to minimize guarantees catastrophic revenue leakage. It must be structured as clinical infrastructure. To solve this, practices are moving away from local hiring cycles and implementing a dedicated virtual infrastructure model. This is distinct from standard medical call centers. These are not rotating agents reading from generic outsourced healthcare scripts. Staffingly provides an elite virtual workforce. The talent pool includes medical doctors, PharmDs, licensed registered nurses, and experienced healthcare administrators. They undergo rigorous, practice-specific training. They learn the exact electronic health record system, the precise scheduling protocols, and the distinct communication preferences of the clinic they serve. Let's take the TMS prior authorization workflow. Insurance verification must begin the exact moment an appointment is booked, not days later. The TMS Verify authorization is structurally vulnerable. Payer guidelines change constantly, and incomplete submissions remain the leading cause of denial. Payers require a rigid 5 to 15 business day decision window for complete files. Any delay or error by an untrained worker pushes back critical patient treatment by weeks. The dedicated full-time equivalent model solves this friction. The exact same virtual assistant remains with the practice, learning the specific patient base intimately over time. That consistency builds therapeutic rapport. A stable, knowledgeable voice on the phone creates a secure, predictable environment for patients navigating complex treatments. By replacing high-turnover local roles with a permanent elite virtual layer, clinics stop managing daily chaos and start operating a resilient system. This human expertise is augmented by artificial intelligence. AI tooling is deployed strictly as a precision support layer to ensure accuracy, never as a replacement. This flowchart details the AI's operational placement as a safety net between clinical documentation and claim submission. It performs diagnostic functions, reviewing every submission for modifier errors and documentation gaps. This precisely targets TMS therapy payer mismatches, catching specific errors that trigger months-long revenue delays. Manual, human-only billing processes typically produce a baseline accuracy rate of 90%. The AI layer systematically closes that 82% gap through algorithmic discipline, rather than relying on the vigilance of an exhausted front desk worker. On the patient engagement side, AI tools scan the clinical schedules. They identify patients with prior no-show patterns and flag high-risk slots for immediate human outreach. AI does not replace the critical live contact required in mental health care. It mathematically guarantees that human intervention occurs exactly where it protects the most revenue. The operational superiority of this model translates directly into an undeniable economic advantage over the bloated legacy approach. A qualified in-house front desk coordinator carries a massive financial anchor. They cost between $28 and $40 per hour fully loaded, factoring in benefits, payroll taxes, paid time off, and recruiting fees. The dedicated virtual medical assistant model operates on radically different economics. A highly trained professional from Staffingly starts at just $8 to $10 per hour. That represents an approximate 70% reduction in operational costs, entirely eliminating benefits overhead, recruiting fees, and internal equipment expenses. The infrastructure meets all mandatory security requirements for highly sensitive psychiatric data. All work runs through encrypted VPNs and is fully HIPAA, SOC2 Type 2, and HITRUST certified. Implementation is rapid. Onboarding a dedicated assistant takes 2 weeks to reach full operation, with many practices going live within 48 to 72 hours. The 5-star review we saw at the beginning wasn't an accident. A highly positive first experience is the mathematical result of applying a fully trained infrastructure from day one. Mastering the administrative layer is a core revenue protection strategy. It eliminates friction and buys back the exact clinical hours necessary to solve the national 48-day wait for care. Rebuild your administrative capacity. Staffingly operates on risk-free, month-to-month engagements with a 30-day free trial available. Visit staffingly.com/demo or call 800-489-5877 to schedule a strategy call today.